Colleagues and friends, good day and warm greetings from Johannesburg. It is such a pleasure to join this virtual dialogue on advancing the use and evidence as it relates to resilient and respectful reproductive, maternal, newborn, child and adolescent health systems in sub-Saharan Africa. I thank the East Central and Southern Africa health community for inviting me to give a few remarks. For UNFPA, the United Nations Sexual and Reproductive Health Agency, resilient and respectful RMNCAH is central to our mission of delivering a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. The COVID pandemic has sent really shockwaves through our societies and economies, revealing, amongst others, the inequities and the fragility of our health systems, and compelling us to adapt and to look for new solutions to deliver our mandate. The diversion of attention of critical resources away from the provision of sexual and reproductive health services, including maternal health care and gender-based violence-related services, is likely to result in exacerbated maternal mortality and morbidity, and increased rates of adolescent pregnancies, and we see that, HIV and sexual transmitted infections. Indeed, we are carefully looking at fertility patterns and seeing how they shift, and it's not clear whether post-2020 we will see a baby boom or a baby burst. One thing is for sure, the 2020 COVID-19 year will be a historic milestone in our demographic, health, and development journey. And rather than holding us back, I think the COVID challenges to our march for universal sexual and reproductive health is catalyzing new ways to ensure sustained actions and investments for sexual and reproductive health care. A year ago at the Nairobi summit, the global community came together to reflect on what has been achieved since the ICPD Cairo summit in 1994, and ways in which we could expedite our efforts to realize the transformative vision of the ICPD program of action, including what we then defined as transformative goals of zero unmet need for family planning, zero preventable maternal deaths, and zero sexual and gender-based violence, by attaining universal access to comprehensive sexual and reproductive health and rights through really a people-centered and a life course-based proven approaches. We noted in Nairobi that our last 25 years journey, that significant progress had indeed been made in improving our access to comprehensive sexual and reproductive health services. And we saw that in global maternal mortality ratios being declined by 38% from 342 deaths to 211 deaths per 100,000 live births, an average annual rate of reduction of about 2.9%. And indeed, this is a significant reduction, but still much, much lower than the 6.4% annual rate needed to achieve the SDG target of 17 maternal deaths per 100,000 live births by 2030. We saw that 6 out of every 10 women are delivering at health facilities, compared to 4 in 10 in the early 1990s. And 4 in 10 women in East and Southern Africa region are using contraceptives, in comparison to around 3 in 10 in 2010. The adolescent birth rates have declined by 40%, though evidence indicates that at least 1/3 of teen pregnancies are still unwanted or unplanned. And new HIV infections in the region decreased by 30% between 2010 and 2017. And there were 42% fewer AIDS-related deaths in 2017 than in 2010. Many countries have outlawed child marriage and criminalized gender-based violence. And the proportion of young women aged 20 to 24 who report having been married before the age of 18 has decreased by nearly 20%. So yet, despite these important achievements in East and Southern Africa, we still have huge hurdles to navigate to achieve the ICPD goals. further compounded now by the impact of the COVID pandemic on not only health-seeking behaviors, but also on essential health service delivery, including those of sexual and reproductive health care. And so we have a long way to go. Indeed, sub-Saharan Africa accounts for 66% of maternal deaths. And in this region, we have countries where maternal mortality ratios of more than 1,000 per 100,000 live births still occur. Sexual and gender-based violence continues to be appallingly high. And 1 in every 3 women worldwide and on the continent have experienced either physical and or sexual intimate partner violence or non-partner sexual violence. And one of the things that UNFPA is particularly also concerned about is funding for sexual reproductive health and rights, which continue to appear unpredictable and insufficient to meet the needs in most countries. Indeed, the estimated cost of fully meeting the needs of African women for contraception, abortion care, and maternal and newborn care is around $18 per capita per annum, 3 times more than the current level that we are spending. And again, for our continent, the emerging humanitarian settings, climate-related crises, and situations of conflict and post-conflict and disasters significantly hinder progress. So faced with these obstacles to achieve our goals by 2030, I think we must look for opportunities to generate evidence that will inform the strengthening of resilience and respectful RMN-CAH systems. One avenue is universal healthcare, which has emerged as a major goal for healthcare delivery in the post-2015 Sustainable Development Agenda, with the aim of redressing the inequities of public healthcare delivery. The global community at the Nairobi summit last year committed to achieving universal access to sexual and reproductive health as part of universal healthcare by 2030. We can and must capitalize on this momentum by ensuring that comprehensive sexual reproductive health and rights services are an integral part of national UHC benefit packages, financing, and financial protection agreements. Second is really building or enhancing resilience healthcare systems to deliver equitable, respectful, quality sexual and reproductive health information and services during what we call normal times or development times, as well as in humanitarian situations. And many development planning efforts look at this nexus of development, humanitarian, and peace. And in that, we really look for how we build resilient healthcare and the ability to adjust the functions prior to, during, or following humanitarian emergency events. And sustaining these required operations under both these conditions requires agility. It requires us to provide alternate complementary perspectives of learning from incidents and types of disrespectful care, but also just being attuned to what we call an early warning or predictive value, that in these times, healthcare systems would need to shift. They would need to look beyond health providers and encompass health regulations, policy-making processes, administration and management, and resource allocations at upstream. It also will require us to look and anchor not only just in terms of healthcare systems, but the right to health and client-centered health services and the importance of primary healthcare and preventive and promotive community engagement and response. So really grounding it right down at community and village level. The third for us is really the integration of evidence-based advocacy to improve that experience of care. And acceptable care requires that all health facilities, goods and services should be ethical, respectful, culturally appropriate, and safe. And that respectable care should be sensitive to gender and life cycle requirements and designed to ensure, of course, confidentiality and prove the health status of the service user. And indeed, in collaboration with governments, development partners, professional associations, and sister UN agencies, UNFPA is committed to this open dialogue on the importance of addressing mistreatment and violence against women during reproductive health care, particularly during childbirth, and advocate for enabling supportive environments for health workers that really will motivate them to deliver that respectful care, including not only the establishment of health ombuds mechanisms, but simply just good training and monitoring and support. And just, you know, in rounding up, maybe for us, this investment in respectful maternity care as a crucial component of the quality of care experience from women during childbirth in facilities. And research has shown us that expectant mothers, all they want is that kindness, respect, inclusion, and safety. And so improving not only pre-service and in-service midwifery training and environmental conditions, and streamlining of maternity systems by close collaboration with health providers is indeed paramount for us. UNFPA and therefore, you know, has in all these 4 areas really developed partnerships and is working beyond these to ensure that we have data on the incidences, types and forms of disrespectful care and obstetric violence, but also to be able to understand the experiences and put in place the policies that are evidence-based and really, you know, data grounded to ensure that we can improve not only respectful maternity care, but also ensure reproductive justice. Today, a global movement of respectful maternity care is calling for protection of all childbearing women, especially marginalized and vulnerable, such as adolescents, minorities, women with disabilities, to ensure we leave no one behind. And I know that many of you in this dialogue are doing everything in that movement to really ensure that we can, you know, really listen, involve women and adolescents in their communities and build in their preferences into policies and capacity building initiatives, feedback loops and accountability measures. And so as we round off this International Year of the Nurse and the Midwife, we should also not overlook the needs of health workers. And in a way, that's where I would like to end. They must be recognized for the essential role they play at the front line and provided with the adequate resources, incentives, remuneration to enable them to provide quality care for all. Human resources for health remain the most critical building block for the achievement of rights of good health and well-being for all. In April this year, I wrote a reflection on why it is imperative that we place nurses, doctors, and midwives' needs and rights at the front line of government's response to the COVID-19. And I wish to close with these words that I wrote in April. It is a moment like this that I am especially proud to have chosen to be a public health physician. And I extend my sincere and deep gratitude to the medical fraternity, and especially to nurses and midwives who have already given us so much of themselves. We salute you for your ceaseless efforts to care for humanity. I thank you.
Good afternoon. I'm Gabriele Fontana. I'm the Regional Health Advisor for UNICEF for Eastern and Southern Africa. I want to thank EXA and partners for inviting me to deliver this keynote. And I want to welcome everybody. I was asked to articulate in a few minutes what are UNICEF priorities in the region and how is the situation, has the situation evolved, and what we would like to see in terms of evidence generation and research, and how we can make the best out of efforts like the one that we're being part of today. And I would start saying something that I would have said maybe even a year ago, before COVID. The MDGs have been a success story. Under 5 mortality in the region decreased significantly. Newborn and maternal mortality not as much, but still decreased over time. For the SDGs, we're not as confident that we'll have a success story at the end. Why? We have a 2.5% increase of the population in the region every year. And we don't have a similar increase on resources in the health system in terms of health professionals or financing of health systems. We don't have an increasing capacity. And so we find ourselves every year trying to provide services to an increasing amount of children. So we're seeing coverage going down. We're seeing coverage of antenatal care going down, postnatal care. The number of unimmunized children is increasing every year. Our target is to decrease them every year, but we're not making it. It's not a total failure. We're immunizing more children every year, but the children that we don't manage to reach is increasing also every year. Climate change is affecting the region. We know Africa will be disproportionately affected. We have population movement that strain the capacity of health systems. COVID came on top of all of that. And the immediate consequence has been that while the region doesn't see the same mortality that we see in Europe or North America or other parts of the planet, because of the young population, because of probably some cross immunity with other coronaviruses, we'll understand it better over time. But the measures to contain COVID in order not to strain health systems that are already weak to start with have affected the population. And one of the main impacts has been that continuity of services has been challenged in almost all countries in the region. And we've seen the impact on mothers that can't reach health facilities during curfew hours, or people that fear to go to a health facility for routine activities, including immunization or antenatal care, because they fear that they might get COVID there. We see our health professionals strained in so many ways. And we see the funding coming from donor countries being redirected to respond to COVID in those countries in the first place. So the picture is challenging. What are we doing to respond to that challenge of the SDGs that has made worse by COVID? We're focusing on strengthening systems. If we want to reach the most vulnerable population groups, we need strong health systems. That's a lesson that we have learned. Even the strongest vertical programs tend to fail with the most underserved population groups if there is no health system to support them. And community platforms have been mainly what we are trying to strengthen in community health workers. Why? Because training a community health worker takes significantly less time and resources than training a medical doctor or a midwife or a nurse. Granted, they cannot provide the same type of services, but they're back in their communities fairly quickly, and they can do a lot. They can contribute to keep reducing under 5 mortality. They can contribute for early referral of patients that might need a higher level of care, and they can promote a lot of activities and a lot of healthy behaviors in communities. We've been working on several aspects of the health system, supply system, information system, mainly on preparedness for health emergencies. We had the Ebola crisis linked to DRC just a year ago, and countries that had worked on preparedness for Ebola have fared much better when it came to responding to COVID. We know that investing in preparedness, which is another way to strengthen a system, pays off. We are focusing a lot on adolescents. Adolescent pregnancies have been increasing. And urbanization. Urbanization is challenging and depriving people of the social networks that they used to have in their places of origin. And people gravitate to urban settings that are developing without any sort of planning. And they have less access to healthcare, but also less access to a network that can support them, that is very important for health. And we're working a lot also on decentralization. Decentralization has been a trend globally and in the region, but very often has been a political trend, not accompanied by development of capacity at district level or subnational level to manage the very limited resources that are there. So supporting health systems at decentralized level is another priority of UNICEF. All of this to reduce child mortality, maternal mortality, and to help children to achieve their full potential. So to do that, what do we know? What do we need to know? So what do we don't know? We need to know a number of things. And I think that initiatives like the one that we are launching today are very, very helpful. We need to know what efforts that we're putting in place to strengthen systems pay off in terms of increased coverage and ultimately decreased mortality. What interventions for adolescent girls and adolescent mothers are working? I remember Jim Sherry saying once, children of children are the most vulnerable. So the children of adolescent girls in urban settings are among the most vulnerable human beings that we need to respond to. What is working in that context? What strategies are paying off at community level and in urban settings, especially poor urban settings, to reach the most deprived population groups? What is working in terms of integration of services and primary health care? I think where most of us, at least if not everybody, are convinced that primary health care is the way to go, but the how in different contexts is what we are still figuring out. So academic institutions, we constantly partner with academic institutions because you can generate evidence that can inform our programs, can inform our support to governments, can inform national strategies and plans. So UNICEF is very interested in implementation research, in generating evidence, lessons learned, good practices that can inform national programs and our efforts to support governments for children and women. We are happy to explore joint initiatives, knowledge management platforms like this one, linking people, linking resources with co-branded joint initiatives to expand our knowledge and do a better job of serving governments for the well-being of children and mothers in Eastern and Southern Africa. Thank you very much.